Did you know that the prevalence of obesity has almost doubled since 1988? I'm Dr. Mary Pardee. I'm the host of the Modern Wellness Podcast. I'm here today with Dr. Sarah Williams, one of the doctors at Modern Med. Welcome, Dr. Williams.
Thank you. Excited to be talking all about this today.
Yeah, I am too. And I think it's such an important topic. We just went over that prevalence, but almost doubled from 1988 to today, which is a huge increase over just our lifetimes, basically.
Yeah.
Can you talk a little bit more about the prevalence of obesity?
Yeah, absolutely. I'm actually going to go ahead and share my screen so that we can dive into this. So here is a graph that shows how things have changed over time. In 1999, the prevalence of obesity was 30.5% of the population. And now we can see how there's just been this steady increase overall to where now we're at 42% in 2018, which is significant. And we can see also that severe obesity is obviously increasing as well as we go throughout time.
Yeah, and is this just the United States? Or are we seeing it elsewhere?
This is just the United States.
Got it, got it. But
hmm
I believe
But
global rates of obesity are also mimicking something similar, right?
yep, absolutely. So we do see globally that it's increasing across the board too, in both males and females. So I think it was 90% of the countries worldwide are increasing in obesity.
Yeah. Yeah, it's a huge problem. And we're not just talking about aesthetics in terms of I want to be thinner. We're talking about real health implications that come along with obesity. So today we're going to cover what can result from obesity, as well as the science behind metabolism. We're going to go into cases that we've seen at Modern Med about people that wanted to lose weight and successfully did, what the key pieces of that usually look like. And we're going to get through some myths as well in terms of some myths about metabolism and does it really slow as we age and what happens during menopause and perimenopause with weight. So as we were talking about this, I'm like, this is a big topic, but I'm really excited to really give it some of the time that it needs. And if we need another podcast, we will do that, obviously.
Yeah, absolutely. Like you said, it's such an important topic. It's such a big thing in our population that needs to be addressed, and there's so many implications that come as part of it.
Yeah, absolutely. So let's dive into a case first. Let's talk about, you had mentioned a 48-year-old female archetype that came in to see you. So first, what did she come in with complaints of? What were her main symptoms that she talked to you about?
Yeah, so it was really just the weight gain that she was starting to experience in perimenopause. That was the main thing really that she came to me with.
Okay, so she's looking to lose weight. She's around 48. She's in that perimenopausal years. And what weight did she come in at? Did you know her body fat or her BMI, just for reference, or approximate height?
Yeah, so her weight was 156 when she came
Mhm.
into me. We did some blood work and talked about hormone replacement, and we also found out that she had hypothyroidism as well. So we added that into her regimen too.
Okay, so doing thyroid replacement therapy medication as part of it. And any symptoms of perimenopause that she had that were bothering her?
She actually didn't really have too much. Her hot flashes were already improved by the time that she came to me.
Okay, but wanted to go on HRT for other reasons. Maybe it was like bone protection, perhaps, but there was something that was driving that for her.
Mhm.
And what did that look like? And what do you think was the biggest kind of contributor to her losing weight?
Yeah, so I really think what helped was the combination of the hormone replacement and thyroid replacement. We also did a 10-day reset together, which really helped her decrease her calories in the short term to help her get past the weight plateau. We also ended up going on calorie restrictive diet for a period of time too, and increased more walking and movement throughout the day because she was already doing strength training several days a week. And that really helped her get to a really good point. So she got down to 136 pounds and was able to maintain there. It took time, of course. It took us about 9 months to really get to this point, but we really were able to get her to feel better in her body.
Yeah, so about a 10-pound weight loss in 9 months, which is
20
great.
pounds.
20 pounds. I thought she, oh,
Mhm.
right. I thought she started at 145, 156. That's
Mhm.
phenomenal. That's really
Yeah.
great. And what did she say were the differences in how she was feeling, other than just feeling more comfortable in her body? What else for her?
She noticed that she had more energy, her sleep was better, her mood was better. Those are the biggest things that she felt.
Yeah, and I think sometimes we see that with hormone replacement therapy where people may have some little things, but then once they start it, they don't realize how much better they actually felt from having estrogen back in their body and
Mhm.
progesterone at night for sleep. And I don't know if you did, do you remember if you did testosterone with this
We
woman?
did.
Okay, and in terms of you saying that the hormone replacement therapy maybe helped with weight loss, what do you mean by that piece? And we pick it apart, and we'll talk a little bit more about menopause specifically in a little bit, but since people may be wondering.
Yeah, absolutely. So we do see in menopause that some weight shifts can occur with how our fat is distributed. So it overall helped her regulate that better and help her feel better as a whole, so that I think she was able to incorporate more physical activity and regulate her appetite better.
Yeah, yeah. HRT itself, the point I'm getting at, does not cause weight loss. It's always like something that people ideally would like, but just adding estrogen or adding testosterone or progesterone doesn't increase your metabolism and cause weight loss in and of itself, but it can lead to other downstream benefits that could potentially lead to the weight loss.
Absolutely. Yeah, we'll talk about that more in a bit too.
Okay, great. And then let's go over just generally, what are some of the health risks that are associated with being overweight?
Yeah, so it really increases your risk for diabetes, heart disease, high blood pressure. Those are some of the biggest things. We see that when you increase the risk of developing those conditions and develop them, that of course, as a result, we unfortunately increase your mortality risk, which is your likelihood of dying from these conditions.
Yeah. Yeah, and coronary heart disease would go in there as well. And then we see something called dyslipidemia with people who are overweight and or pre-diabetic or, insulin resistant. Do you want to talk a little bit about that piece?
Yeah, so essentially we see that leads to higher cholesterol, which increases your risk for heart attacks, strokes, things of that nature.
Yeah, and specifically, we will see elevated triglyceride levels that will rise in dyslipidemia and really respond really well to lifestyle changes with weight loss and reducing calories and things like that.
Yeah, absolutely.
The other piece I want to talk about is cancer with being overweight. So there was a stat in a recent paper that I looked at that showed people who are overweight have a 1.5 to 3.5 fold increase risk for developing cancers, postmenopausal breast cancer, endometrial cancer, colon cancer, kidney cancer, even esophageal cancers compared to their
Yeah.
normal weight peers. We're not talking about something that's directly metabolic, but we do know that cancers have a metabolic component to them for sure.
Yeah.
And that's pretty significant. So 1.5 to 3.5 fold increase. So then you're getting a reduction in risk if you're able to
Mhm.
move from overweight to normal body weight too.
Yeah. Yeah, absolutely. Wow, that's fascinating.
Yeah. Let's talk about how we talk about
Mhm.
people who are overweight or obese in terms of measurement. So BMI is going to be the standard of care when we're talking about just categorization of these. Can you talk a little bit about what it is?
Yeah, so it stands for body mass index, which is essentially we calculate that just by your height times your weight, and that helps us determine if you're in the overweight category or the obese category. So like you said, that's really the standard right now that we're still using. The issue with that is it can actually overestimate the amount of fat that you have in your body. So the example that we really see is when people are very muscular, they might have a higher weight because muscle weighs more than fat. So they might have a higher BMI, but they actually aren't at risk for these conditions. The BMI isn't always the best marker for us to use.
Yeah, great one. The analogy I used to use was Gronkowski, which I've now, I guess he's
Yeah.
not he's not even playing anymore, right? It just got outdated and I don't know
Yeah.
who is actually playing. But imagine there's these 250 pound really muscular guys who are very athletic. And when you can see abs on somebody, you know that they have a lower body fat percentage.
Mm.
But if you just went weight to height ratio for somebody like that, they can easily come out in the obese category.
Yeah.
And if we're lumping them in that category, we're not going to get accurate results in terms of course, they're not as susceptible to these increases in cardiovascular disease or high
Hmm.
triglyceride levels or prediabetes because metabolically they can be very, very fit, actually.
Yep. Yep. Exactly. So what I really like to use is waist circumference. This is essentially a better marker because it's looking at what we call our visceral fat, which is fat that we are having more in our abdominal region. And we see direct relation to this in how at risk we are for a lot of the diseases we've been talking about, like heart disease, high blood pressure, diabetes, even fatty liver disease. That's really important for us to also assess in combination with the BMI.
Yep. And if somebody is at home right now and wants to measure their waist circumference, how do they do that?
Yeah, I'm actually gonna share my screen again for this because it helps to look at it this way. Essentially, what you want to do is take a tape measure and measure around your abdomen at the top of your hip bones, and that will give us the measurement of your waist circumference. So this typically falls at like the smallest part of your waist.
Okay, and can you just use your cursor to show people what their hip bone is?
Yeah. So right here, you can see that on the skeleton. This is the top of your hip bone. So we just want to measure right above that area, right around your abdomen.
And I don't know how you instruct people, but I'll tell people to stand there, take a deep breath in, then let it out, and then just let everything out. Because a lot of the times we're like tense and sucking our stomachs in, and we're not going to get an accurate measurement there. So to do that in and then out and see where you land can be helpful. And
Yeah.
what do we know in terms of waist circumference in terms of health for men and women?
Yep, absolutely. If you are a male and it's greater than 40 inches, or if you're a female and it's greater than 35 inches, you're at risk for these diseases that we've been talking about.
Yeah, yeah. And so we really want to keep the waist circumference as one of the factors that we're talking about to look at that. It's called android fat or also associated with visceral adipose tissue, like you were talking about.
Mhm.
What are potential causes of weight gain and obesity? Maybe we start from like pretty obvious, big picture, and then get a little bit more narrow.
Yeah. So I mean the basis of it is we're going to gain weight if our energy intake exceeds our energy expenditure. So essentially we can think of this as how much we are consuming exceeds how much we're actually able to burn. That's really what leads to weight gain itself. And the factors that play into that, the biggest ones are really diet and physical activity.
Okay. But Dr. Williams on social media, I read that calories don't matter and it's not just about calories in, calories out. What do you think about that?
Unfortunately, that's just not true. Even if we're eating like good quality food, if you are exceeding your caloric intake and not able to burn it, then you're going to gain weight over time. So, calories in versus calories out is definitely the biggest thing when we think about weight.
Yeah, and I think sometimes people throw away the baby with the bathwater in this one where they say, oh, so you're saying quality of food doesn't matter, or you're saying it doesn't matter what I eat. And that's definitely not what you're saying. What
Yeah,
you're saying is the big picture thing here is that calories in have to be lower than calories out in order to lose weight. And if calories in are more
exactly.
than calories out, we are going to gain weight. It's just like the law of thermodynamics.
Exactly.
Um, and it's usually easier to lower your calories when you're eating a bunch of fruits and vegetables that are high in fiber, higher in water content, lower in calories, of course.
Mhm. Yep, yep, exactly. To your point, of course, quality matters to a certain extent, but ultimately, yeah, if the calories in is exceeding calories out or how much you're able to burn, then it's just still going to happen, unfortunately.
Yeah.
But of that, we do have research showing that diet plays a role. For instance, ultra processed foods have definitely been linked to risk for gaining weight, which I think is fascinating, but makes sense. So ultra processed, I'm referring to foods that like go under a lot of different processes to become what they are. So we think of things like crackers and chips and pizza and soda and cereal. All of those things, or the boxed foods in general, can be very processed. So I found this really interesting that they showed that in this trial, and it was only 20 people, so I know that that's small, but they showed that even just for 2 weeks, if you were eating an ultra processed diet, you consumed an additional 500 calories a day and gained 2 pounds. Whereas for 2 weeks, if you followed an unprocessed diet, you actually lost 2 pounds.
Wow. Yeah. Small study, but like definitely warrants looking at further and makes a ton of
Yeah.
sense, right? Like it just makes a ton of sense when we talk about nutrition and caloric density and things like that.
Mm.
My guess is that a big percentage of that effect is due to not necessarily the unprocessed piece of it, but the hyperpalatability piece of it.
Mhm.
And I think those things go hand in hand many of the time. I think that there's exceptions to the rule, meaning if we took celery and we dried it and cut it and made it into celery chips or something like that, that's still highly processed, right? Like we could make it into a
Mhm.
flour and then make it into like dinosaur shape, and we'd still consider that highly processed, maybe, I think. But it wouldn't have the same effect on the obesogenic effect. Whereas if
Mhm.
we take a potato, cut it up, make it into a dinosaur, add a bunch of oil, add a bunch of salt. Now we have a potato. I don't know why I'm using
Mhm.
dinosaurs, but
Yeah.
like now we have like
I
potato
like it.
dinosaur chips.
Yeah.
Um,
Chips.
then I'm
Yes,
thinking of those little
exactly.
dinos that
Mhm.
you make chicken nuggets out of,
Yeah.
and I just made up
Mhm.
potato chips. But
Yeah.
so for that piece, it's like this hyper palatability piece of it,
Mhm.
where when you add sugar, salt, fat
Yeah.
to anything in that combination specifically, then we're much more likely to overconsume it.
Exactly. Yeah. Yeah, I agree.
Let's talk about the physical activity exercise piece of this.
Yeah. Yeah. So this is interesting. What we've seen change over the years is our level of physical activity. So, for instance, in 1960, 50% of workers in the US had a moderately active job. And in 2010, greater than 70% had a sedentary or light workload. So that alone, we're just much more sedentary than we used to be. And then I'll share my screen again too, because this also will show how our physical activity has changed over the years as we age. This was done in 2020. We can see this is the age groups over here. So we just see 18 to 34, we are more active. We're meeting these guidelines, which are listed down here. So essentially, moderate intensity aerobic activity for
Yep.
150 to 300 minutes. And then the strength training aspect of 2 days a week or more is what they use for this. We can see how just as we age, for both males and females, we just decrease our overall physical activity and don't meet these
Yeah, and if
guidelines.
you're listening on Apple Podcasts or Spotify or something, definitely worth going to YouTube or our website to look at this video, because this is something that we don't talk about enough, that people will often use it as the reason where they say, well, my metabolism is slowing because I'm 45. And this really
Yeah,
shows a big part of why that's not true and what's actually going on here. But just reading some of these numbers out loud, am I saying this right? Where men
yeah,
who are 18 to 34, 41.3% of them are meeting that guideline of 150 to 300 minutes a week of moderate intensity,
exactly.
or
Yeah.
75 to 150 of vigorous intensity.
Hmm.
Whereas when they become 35 to 49, it drops from that 41.3 to 29.4, with
Hmm.
just that drop. And then when you get to 65 and over, you went from 41.3 in your 18 to 34 years to 15.3% of people
Yeah.
meeting that recommended amount.
Yeah. That's staggering.
That's staggering. And then you compare men to
Yeah.
women, and that's actually
Yeah.
surprising to me. I didn't
Hmm.
know that there was that big of a discrepancy of women, a fewer percentage of women meeting that cutoff in all age
Yeah.
groups.
Yeah, yeah, absolutely. I mean, so it's 28% if you're 18 to 34, and then greater than 65, it drops to 10%. So, yeah, overall, females don't meet the guidelines as much
Yeah.
as males.
Come on,
Mhm.
ladies.
Yeah,
Let's
let's step it up.
I wonder, yeah, I wonder if there's anything else that are confounding these in terms of like the populations that they sampled or anything like that. But regardless, it seems like a quite obvious trend that they're looking at in this population.
Yeah, yeah, absolutely. So really important to keep in mind. I love what you said. It's not just, oh, our metabolism is slowing down. It's really we're actually not as active as we age.
Yeah, not even close as active. We're talking about like
Yeah.
a third of the people who are meeting the requirement. So there's a much fewer people who are doing it.
Yes.
And the other thing I wanted to repeat is that the first one that you said is actually really interesting, where it's in 1960, 50% of the US workforce was moderately active.
Yeah.
In 2010, more than 70% of workers are either sedentary or very light physical activity. So it
Yeah.
completely flopped and reversed, where half of the population was moderately active, and now over 70% is doing virtually nothing for their job in terms of activity level during the day.
Yeah, yeah, exactly. A lot of us are like sitting at desks all day, which is why I know you have your walking desk, but things like that are really important, or taking breaks throughout the day and getting more steps in. That's really important to balance it out because we can't always change our job and that we're on computers more these days, but we really need to be mindful and aware to incorporate more movement in other ways then.
Yeah, yeah. And I like to talk about movement and exercise a little bit differently. Scientifically, they're not like anything that's moving your body is going to be burning calories, but I think it ends up being easier for people to lose weight if they're not just exercising once a day for an hour, but they're also active throughout the other periods of the day, where they're, like you said, like
Absolutely.
going for a walk at lunch or taking the stairs instead of the elevator. All of these little tiny things can add up over the course of the day.
Yeah, I find that to be so impactful.
Okay, let's talk about something that's not so obvious in terms of causes. We've heard about it in the news for sure. Some of it has created a lot of controversy. People can just be honestly quite mean on social media about this, but genetics do play a role with obesity and our weight. Can
Yeah.
you start to describe how it influences it and what that looks like?
Yeah, absolutely. So it's actually a pretty significant piece. So about 40 to 70% can be attributed to genetics. We find also that if you have one parent who is obese, your risk of being obese increases by 3 to 4 times. If both of your parents are obese, your increased risk by 10 times. That's really significant. I think there's a lot of things that are playing a role with that too. You're exposed to the environmental piece on top of that. But we do see that there are over 200 genes that can play a role with your development of obesity. We see that they impact a lot of different pathways, like how you regulate your appetite and your fat cell function and your overall metabolism and how you burn energy.
Yeah, yeah, and it's a big piece. Does it mean, let's say you do have mom and dad are both overweight, and it really feels like there is a genetic component. It's not just environment and lifestyle piece of it. Does that mean you're just going to be obese and there's nothing we can do about it? How do you talk to people about that?
Yeah. No, it really doesn't mean that. First, I always like to say genetics load the gun, but environment pulls the trigger. So you might be more susceptible, but that doesn't mean it's going to happen. But it might mean that it's going to be a little bit more difficult. You might need to be a little bit more aware of your food choices, your lifestyle choices, things like that. But there are so many different ways that we can also combat that. And some things we'll be talking about later as far as like other therapies and treatments that can be helpful too.
Yeah, yeah. So it's not predetermined in terms of there's nothing that you can do about this. There's always going to be things that can work and ways that you can regulate your body, but like you said, could be more difficult for some people. We
Yeah.
talk a lot about gut health, the gut microbiome. It's such an interesting
Always.
topic. And there's a little tie here with just our metabolism in general and the gut microbiome. Let's go into that.
Yeah, yeah, they have found an association with the different types of bacteria in our gut being potentially linked to the development of obesity. So, the specific proportion between Bacteroides and Firmicutes is what we've seen so far, but we don't know enough yet to say if this is like, okay, you have this bacteria, this is what's causing obesity. We can't say there's like a clear correlation yet, but we're seeing some association that there might be some connection here.
Okay. I thought the Bacteroides Firmicutes ratio was disproven. Have you seen anything about that?
Mm, no, I haven't.
No? Okay, well, we'll look it
No.
up after, and if you're listening to it, it's because it's still good. Let's talk a little bit about endocrine disrupting chemicals.
Yeah, so important. So we actually have really good research now showing that these different endocrine disrupting chemicals can be associated with gaining weight. Specifically, the two most common ones with weight are BPA, which is in plastics, and perfluorinated chemicals, which is found in our water or nonstick cookware. These have been linked to increasing weight.
Yeah, okay. Okay, big topic that we talk about with patients every single day is menopause and weight gain. So I'm trying to think of the best way to go through this, but let's just talk about the changes in menopause that start to happen that can influence body composition.
Yeah. So when we start to enter into those menopausal years, our estrogen starts to fluctuate and overall with time will decrease. And so we have seen that when our estrogen decreases, it can lead to a change in our body composition. So we're more likely to store fat in that abdominal region, which, as we talked about earlier, can increase our risk of different diseases. We also can see at this time that our lean muscle mass can also decrease. That can be why we see these changes happening in our body is really due to this decrease in estrogen is really the main contributor.
Yeah, yeah. We start to see over the age of 45, 50 that sarcopenia, just muscle loss in general, can really start to accelerate and can be really helped sometimes by the use of hormones to make it a little bit easier to keep muscle on your body. Other things that can happen during menopause that can make weight loss more difficult or perimenopause.
Yeah. Well, just in general, you typically aren't feeling as good. So you might not be working out as much. You might overall increase your caloric intake, maybe without even knowing, just because you're not feeling as good. And there's all these changes and shifts happening in your body. So that can definitely be a contributing factor too.
Yeah. And then just taking into consideration that menopause is going to be happening, perimenopause, happening starting in your 40s and then menopause going into the 50s. If we look back at that chart of physical activity, we really see that the physical energy expenditure is dropping as we're aging too. And so factoring that all in with increase in appetite, potentially reducing in physical
Hmm.
activity just outside of menopause, because it's happening in men as well. So there's
Yeah.
definitely just a trend as we age, and then you compound that with hormonal shifts that can affect appetite. It's no wonder where we can see weight issues start to begin.
Yeah, yeah, exactly. It's just a roller coaster that we're on with all these things that get compounded on top of each other at that time.
Yeah. The other study I wanted to talk about before we go into testing is that 2021 study that I had sent over to you the other day. And this is just getting back to the fact that there is this myth that metabolism slows as we age. And the study looked at thousands of people and they measured their total daily energy expenditure and their basal metabolic rate. So if you're just sitting on the couch all day, how many calories are you burning?
Mhm.
And what they found is that between the ages of 20 and 60, our metabolism does not change. We're
Yeah,
not burning fewer calories if we are taking into consideration how much muscle mass we have on the body. So if you lose muscle mass during your 30s or 40s, then your basal metabolic rate will reduce, but it's not due to a slowing of metabolism. It's due to the fact that you lost muscle mass and aren't burning as many calories. And I think this can
yeah.
be really empowering for people because people come in all the time. How many times have you heard, well, I'm 50, it's just my metabolism is slower now, I can't
Mhm.
eat as much,
All the
right?
time.
all the
Yep.
time. We hear it all the time. And I think it can be empowering to be like, it's likely not your metabolism slowing. Like you still have that engine and it's still
Mhm.
ready to rev. But if you have reduced your muscle mass or reduced your activity level, then
Yeah.
yes, of course, it's going to be more difficult to lose weight. After the age of 60, they did see a decline in basal metabolic rate, but it was 0.7% per year. So even after the age of 60, really
Mhm.
small declines in your metabolism, basal
Yeah.
metabolic rate.
Yeah. Like you said, that's so empowering to know. And this study is so fascinating to be able to break that down for people and realize like our metabolism really ultimately isn't changing. That's not what's happening. There's something else at play here.
Yeah, and people often feel like they're broken or I can't win and I get it. I'm not trying to gaslight or make it seem like, you should be able to do more. It's difficult for sure. And our lifestyles are not designed to be super active with how much we're in front of the computer, but also to know that it's not likely that you're broken. It's likely that some of the levers have dysregulated and we need to get everything back in line, and then you should
Mhm.
be able to start to lose weight.
Yep. Yep. Absolutely.
So someone comes in, let's just take an example, a 50-year-old male, he's 20, 30 pounds overweight. You're going to do a full intake with him. What lab work would you want to make sure that you're also doing?
Yeah, we always want a blood sugar regulation, your HbA1c and insulin. Always looking at your thyroid too is really important because that can absolutely affect your metabolism and cause weight gain. Just general inflammatory markers are good to look at, and sex hormones are good to look at too, especially in the male. We definitely want to look at testosterone, see if that's playing a role. Then another thing that I always like to do when we are managing weight is a DEXA scan, which is where we're able to really get a deeper dive into your lean muscle mass versus your fat mass. And we can really dictate a lot from that of how we want to approach and get a really good baseline.
Yeah, yeah, we actually just sent out a email yesterday about DEXA scans. Our patients get a discount on DEXA scans, and so if you're listening to this and you want to become a patient, email us. We can get you that discount on a DEXA scan. I just reviewed with a patient one of these, and they're so valuable. It's way different than looking at it and saying, okay, you're 150 pounds. Like, what does that
Mhm.
mean? What's actually comprising that 150 pounds? What are the key things you're looking at when you look at a DEXA scan?
Yeah. So one thing that we look at is your appendicular lean muscle index, which is where we can actually see, okay, we need you to gain X amount of muscle to help support you against osteoporosis and heart disease, metabolic disease, things like that. So that's a really important marker that we get from that. Of course, the fat percentage itself is important to look at because we want that to be under a certain threshold to be optimal and protect you as well. And then we also get to look at visceral fat, which we've been talking about throughout, which we get to see how much is stored in your abdomen and work on that too.
Yeah, great. I think it's important when you're starting your weight loss journey is to just have certain expectations about what is common. Often people will come in and they'll say, I want to lose 20 pounds in the next, 2 to 3 months. And I think expectation setting can be really helpful at just saying, okay, what is this more likely going to look like on your journey? Can you talk about some
Mhm.
of the key things that you mentioned with patients in this discussion?
Yeah, especially when we're really working on lifestyle measures, what we expect to see is about a 5 to 7% decrease in weight. How I would break this down is say if you're 160 pounds, that would be an 8 pound weight loss. So to get you to 152 pounds would be like a good goal, especially when we're just working on lifestyle. Another way to break this down is essentially looking at how much calories you need just to maintain at the weight that you're at. And then we break it down based off of that. For instance, you need 22 calories to maintain every 2.2 pounds of weight. If you're like 220 pounds, you need 2,200 calories to maintain. We would cut that by like 500 calories, and that would give you a weight loss of 1 pound a week with that 500 calorie deficit. So, like 1 pound a week, if we're doing a 500 calorie deficit, is what would be the overall expectation.
Okay, and a lot of numbers were just thrown around there. So you can also measure your basal metabolic rate. So I have a device that'll bring patients into the clinic and we just throw a mask on you, not harshly, we gently place the mask on you. And based on the oxygen and carbon dioxide that's inhaled and expelled, you can dictate how many calories you're actually burning at rest. So sometimes that's an easier way versus using the calculators, but a lot of the times the
Mhm.
calculators that you just mentioned will be enough to initiate a weight loss, and then sometimes you have to get more specific after that. But I want to go back up to the 5 to 7%. So if somebody is 300 pounds and needs to get to 150 to be a normal body weight, how does that 5 to 7% play a role? I'm a little confused on that one.
Yeah. So essentially it would be harder to get to that amount of weight loss without other interventions beyond lifestyle, especially depending on the timeline that you have.
Got it, got it, got it. Okay, so you're saying lifestyle alone. That's got to be dependent though on what lifestyle was when they first started, right? Because somebody who's
Yeah.
eating Big Macs, three at a meal every meal and not exercising, you're going to be able to lose way more weight than somebody who's eating a whole foods, plant-based diet, lean proteins kind of thing.
Yeah, I would imagine.
Okay. Let's talk about just initial management if somebody comes in, how you're talking to people about weight loss.
Yeah, so the biggest thing is the diet and physical activity, of course. It really goes back to what we've been talking about is reducing the overall caloric intake is the biggest component and working on more of balanced diet where we're eliminating like excess carbs and sugars. A lot of people are having like sweetened drinks and sodas and more processed foods. All those will be inhibiting for weight loss. So working on the dietary piece and decreasing overall calories and putting you in a deficit is the biggest thing.
Right. What are your thoughts on intermittent fasting?
Yeah, so I do think intermittent fasting can be helpful. When we're talking about intermittent fasting, it's talking about eating in a certain window, say like an 8-hour window is common, like from 10 to 6. It can be helpful because typically what's happening is you're overall eating less in that window of time than if you were eating over a longer period of time. It's not actually that intermittent fasting itself helps you lose weight. It's that you are typically eating less calories because you're eating in a less amount of time.
Yeah, yeah, that makes sense. And I think the same exact thing. I want to talk about protein with weight loss because it's something that we talk about with all of our patients. What's the importance of protein on this journey?
Yes, protein is so, so important. It's one of my number one things that I talk about with patients because it really helps to regulate your appetite and satiety. We actually have some research that shows that, especially if you start your day with a higher protein breakfast, that you are going to be more satiated throughout the day and you'll overall eat less calories as well.
Yeah. And we definitely see that. And I just feel it too. Like when I'm eating a good amount of protein, I'm way less hungry throughout the
Hmm.
day.
Yeah.
Let's talk about some medications. We prescribe medications in our practice for weight loss. I think that they're a really important piece of the tool belt that we have. What are some of those and what does that look like?
Yeah, absolutely. So they're really blowing up right now. The GLP-1 agonists, so things like semaglutide, Ozempic, those are really impactful at helping with weight loss. Essentially, they will increase your release of insulin and they also reduce your appetite because they slow down your stomach emptying and they help you feel more satiated. So they work on a couple different pathways, but essentially they're really effective at helping people lose weight.
Yeah, they really, really work. The studies are showing reductions in cardiovascular risk, reduced
Hmm.
rates of inflammation. People that are having arthritis are getting relief from these medications as well.
Have
They're
so many
not for
benefits.
everybody. Who are you more apt to be prescribing GLP-1s to?
Yep, I'm more apt if the patient is actually obese, and especially if you've tried all of the diet and lifestyle things and things just aren't moving the needle enough, that would be when I would consider it.
Yeah, and we're going to do a whole separate podcast just on GLP-1s. So we wanted to cover weight loss at a broader lens in this podcast, and then we'll start to narrow in on these individual therapies. Let's also talk about caffeine and weight loss because there's again some myths that float around that you shouldn't drink coffee if you're trying to lose weight because it increases cortisol. Write that down
Yeah.
for us.
Yes. Yeah. So caffeine itself can actually be really, really helpful for weight loss. It will overall increase your energy expenditure, so how well you're like burning calories. It helps with fat breakdown. It can also suppress your appetite. So it works in a couple different ways, but we see this in the study. It's pretty clear that it can really help caffeine itself. But really important what you brought up about cortisol and caffeine. So when we do drink caffeine, it can increase our cortisol, but that does not mean that that's going to negate your weight loss. Cortisol itself, we want it to be high at certain times. So like we want cortisol to be high in the morning, what helps with our energy. We also get a cortisol surge after exercise and after caffeine. Those are normal responses and are overall helpful for our energy and metabolism and weight management. Of course, we don't want our cortisol to be chronically high, but that would be a condition called like Cushing syndrome, where it's continuously high and that can cause weight gain. A normal person having these, cortisol spikes, cortisol highest in the morning is not going to inhibit your weight loss.
Yeah, and if you're really trying to lose weight, does it make sense to then avoid caffeine?
No, it is
No,
not.
that's the exact
It will
opposite. Yeah.
absolutely help you.
And some people still get anxious, like it's still not
Yeah,
great for some people, right? But in
exactly.
general, all the things that you're seeing about don't drink your coffee before whatever because it's going to spike your cortisol and you're trying to lose weight. What they do is they use these mechanisms of like, if this, then that, and then they try to
Mm,
tie them all together. And that's just not how human physiology works.
yeah,
So we have to look at the actual randomized control trials, which clearly state that drinking caffeine can lead to weight loss and reductions in appetite.
yep, yeah, 100%.
Okay, what about carbs? So I'm trying to lose weight. Do I have to avoid carbohydrates?
No, there's no need to completely restrict all carbohydrates. What I would say is we want to focus on the less processed, more whole grains, like non-starchy vegetables, fruits. Those are still really good quality carbs. Like you mentioned earlier, you're getting fiber with that. That can also help with regulating your appetite and satiety. So we want to focus more on those versus the processed refined carbs like white breads and pastas and baked goods. Those things are going to have a higher glycemic index that can really impact your weight. They also will decrease your satiety. So you're often reaching for more food. You're overall increasing the amount of calories you're consuming. So no, all carbohydrates do not need to be avoided, but we definitely want to limit some and focus more on others.
Yeah. Yeah. And I mean, technically, you could, and people are going to hate this, but you could eat pure sugar and lose weight. And I'm not suggesting this, like, disclaimer, I'm definitely not suggesting this, but you could eat white bread and popsicles, like just pure sugar, and you could still lose weight. So it is not the carbs that is causing weight gain.
Yeah.
You have to first look at calories. So if calories are below a certain threshold, you will lose weight. I love referencing the show, what is it called? Alone on,
Mhm.
what is it, Discovery Channel or I don't know, but there's a show where they literally take people and they put them on a deserted island by themselves
Mm,
with just a backpack and an axe and maybe a knife and like one match or something like that. And these people spend up to 30, 60 days in nature by themselves. And without an exception, regardless of a person's weight when they entered the contest, when they leave, as long as they don't leave the same day, their weight is lower. And
mm,
most people, they're actually doing med checks. They're going and checking these people's weight to say, do they have to pull them because they get too
mm.
low weight?
Yeah.
But sometimes these people are only eating berries, which is going to be mostly carbohydrates, or
Mm,
a lot of the time they're trying to find fish and things like that. But regardless of what they are eating or not eating, they are losing weight because calories are at an extreme deficit in that
yeah.
case.
Yeah. Yeah. That makes sense that that would happen.
And then we have like the McDonald's experiments, right? So those people that have
Yeah.
put themselves and just eaten McDonald's for 30 days and have lost weight. And again, not
Yeah.
recommending it. High saturated fat, we don't want that for other reasons. And vegetables have so many benefits for reducing the risk for cancers and other things. But if we're
Yeah.
talking about just the mechanisms of weight loss, calories are king, and then we want to go into quality of food for satiety reasons, maintaining muscle mass, reducing the risk for certain chronic diseases as well.
Yeah, yeah, absolutely. That those are both really good examples of what really matters, calories in versus calories out.
Yeah, yeah. And then we can fill it in with all the other things that are going to benefit you as well.
Yeah.
Anything that we didn't talk about today that you want to touch on?
I think we covered a lot of really good things.
Yeah,
This is
awesome.
helpful
Thank
for
you
people.
for absolutely. Thank you for diving into this. There's a ton of good stuff in here. We'll return with the GLP-1 agonist in the future podcasts. Email us if you ever want us to do a podcast on something specific. If you're interested in ADEXA or working with Dr. Williams directly, on our website, you can book a complimentary phone consult with her, and just follow us on Instagram and see other free content that we're posting as well. Thank you so much, Sarah.
Thank
We'll talk to you
you.
soon.
Sounds good. Take care.